Hello, I'm Victor Montori, co-founder and chair of the board of the Patient Revolution, an organization focused on bringing about careful and kind care for all. I have no disclosures to make. I work as a clinician and derive my income from that salary, and as a researcher with a research group that does not take and has never taken for-profit funding. We published this book, Why We Revolt, A Patient Revolution for Careful and Kind Care, and all the funds go to the organization, the Patient Revolution, and not to me. I would like to start by talking about care. This image is an example of many that we see on a day-to-day basis of humans connecting with humans and caring. Caring is a central aspect of our humanity. And yet, we take it for granted, and we see it even disappear from our language when we're talking about care. And it disappears when we add adjectives to modify it. We talk about sick care or health care. We talk about patient-centered care or evidence-based care or high-value care. And the moment we put those adjectives to it, our attention is drawn to them, and we leave care undefined and without significance. But care is important and significant. Care is both a practice and a disposition. It is the practice of noticing and responding, of noticing the person in need and their situation by being present, understanding their situation in high definition, not only in their needs, but also in their strengths. And then choosing, taking responsibility and choosing to respond. And by doing that, creating the possibility that that situation can be improved, giving that person hope. It is also about giving and receiving. Giving care, which is working with the person, not onto the person, but with the person in need, with competence, otherwise we could do harm, and with compassion. And care receiving is important because it's the only way to know if our response has been pertinent, adequate, and desirable, given the situation. Now, when we approach the person in need, it's critically important that we only do it with one intention, and that's the intention to care. Additional purposes, additional intentions create the possibility that there might be other reasons, other motivations for the approach, and that reduces trust, and trust is essential often to achieve the outcomes of care. It is also important that in the ongoing process of caring that we foster these enduring relationships that allow us to recover from the most common outcome of being alive, experience disease, and care, which is disappointment. It is that enduring relationship that allows us to regroup and come back. It is the source of resilience for patients and clinicians. Now, what stands in the way of care? I'm going to describe a few pathologies of care that make this very hard. One of them is blur. Seeing the patient in healthcare, seeing the patient too fast, or seeing them as a test result, the high hemoglobin, the A1C, as a statistic, the uncontrolled person with diabetes, or as a medical record, the illusion that we know somebody because we've read through their record and we know their results, leave the picture of a person as blurry. Here is Maria Luisa, who has joined me in presenting this for over a decade. And Maria Luisa sits here with a lot of healthcare, and yet she does not look particularly healthy. How do we respond to Maria Luisa? Well, we have guidelines and targets and therapeutic innovations, all of which respond to what's common to people like Maria Luisa, which is their common biology. It allows us to care for people like Maria Luisa, but that is not the job. The job that we have is to care for Maria Luisa, and that requires us to fully understand not just her biology, but also her biography. Where is she coming from? Where does she want to go? How does her life color the experience of disease, and how are her circumstances affecting the efficacy and the safety of her treatments? Understanding her situation in high definition. Without this, our treatments are generic, and they accumulate. They form patient work. This is from a project where we ask patients with diabetes to take photographs of the things that give them work. And so patients with diabetes are thinking about what they have to eat, so they took photographs of nutrition labels because they have to do the math, the carbs and the calories coming from different meals. They also took a picture of the glucometer. They have to check their sugars and use the numbers to calculate how much treatment they need to take. But also because insurance companies keep changing their deals with the providers of these machines, and they send them the patient's free machine, and the patient has to buy more of those test strips. And these machines have interfaces that are very antiquated, where you have to click on the buttons long enough to change the date or to add information or to see what's in there. And each one has a different interface that the patient must learn. But by far the most common picture we got were pictures of waiting. Waiting at home, waiting for a phone call, waiting for an appointment, waiting in the waiting room, waiting in the office, waiting for a test result that perhaps determines whether the treatment worked or not, waiting to hear from the insurance company, pre-authorization for a necessary treatment. Waiting. It's the way healthcare tells patients, your time is not important to us. Waiting. Because of all this work, and because this work is invisible to healthcare, oftentimes when healthcare needs something done, they think, oh, let's use the patient and their family for this, and new work accumulates. New work that includes expecting patients to come prepared for the consultation. Watch our educational video. We had our doctors are hilarious on YouTube. Come organized with your information, bring questions, be ready to ask new ones. Record the visit. I can speak at full speed, and then when you go home, you can slow it down and share it with your family and friends, and they can review what's going on. Review our medical records. Sometimes we take mistakes into it, and you can help us fix it. Communicate via the portal. No, we don't use text or email or WhatsApp. You have to use this system. It's more secure. And we ask you to transmit the data from your smartwatch and pedometers. We're not going to look at it, but it keeps you engaged. We want you to self-measure, self-monitor, self-manage, to manage your appointments, your prescriptions, your bills, your denials, your delays. We want you to overcome the disadvantages of your illness, of those labels that the illnesses have, of your resources, and of your identity. We want you to keep your family and important others informed. We want you to take care of your significant others while you're sick, and don't forget to advocate for yourself and advocate for others. Each of this, I think, is a reasonable expectation that we might have of patients, but it accumulates into a substantial amount of work that is overwhelming people, produces a burden of treatment. And when patients don't do what clinicians expect them to do, clinicians place this label on them, non-compliant. The person is non-compliant, which is a label that describes a person's character, not their situation. It says Maria Luisa is not taking personal responsibility for getting better. And it's a sticky label. It's a label that once a clinician places on one patient, when that patient goes to another clinician, that label comes along and tells that other clinician that it doesn't matter what that other clinician will do, that the patient will not be there as a partner for that care. And placing a label that denies care to someone who comes in for care is profoundly cruel. So instead of the care of noticing and responding, what we get is industrial processing of patients, industrial healthcare. Industrial healthcare in which patients are a blur, their treatments are generic and burdensome, and cruelty is often present. Without care, healthcare is not humanly sustainable. What evidence do we have of that? Well, when we've interviewed patients, 40% of patients with chronic conditions describe that they're overwhelmed by the healthcare that they have to implement in their lives. When they come to the consultation, 40% of the agenda, of the discussion that we have with patients, is with a clinician documenting care in the medical record instead of caring, interrupting the patient within 11 seconds of their initial statement as to, why are you here? How can I help? 11 seconds. And 60% of our clinicians are experiencing exhaustion, symptoms of depersonalization, and loss of empathy, burnout. What is the solution to this problem of lack of care in healthcare? I think the Cathedral by Rodin gives us a clue. To make this beautiful sculpture, Rodin had to remove the marble from outside these hands, to reveal the hands. Hands that are of two different people coming together. Hands that configure the walls of the cathedral, that create that space in between, that sacred space of the inside of the cathedral. And to achieve that space, Rodin had to remove every piece of marble that was standing between these two hands. The solution to bring care into healthcare is to create that space, create those conditions for care, and we must work together to create the conditions for care. We will know we have that when we can see unhurried conversations. Because in an unhurried conversation, which doesn't have to be too long, doesn't have to be slow, doesn't have to be wasteful, it just has to be unhurried. Unhurried enough so we can appreciate the patient's situation in high definition, and we can co-create with the patient a response that makes sense intellectually. It's based on science and responds to the situation as we understand it. Makes sense emotionally, attends to the emotional elements of the situation, and it makes sense practically. It's feasible in the life of the person. It doesn't overwhelm themselves or their families. And the unhurried conversation is that space where this can take place. And we need to create the conditions for unhurried conversations. That process of co-creating a plan of care is sometimes called shared decision making. And for instance, to create the conditions for shared decision making, we can pay attention to the space in which it occurs. Here is an office without any distractions, without any possibility of interruption or disruption. We have a table that is a semicircular table that is indicating on the structure itself that we're going to be sitting shoulder to shoulder to collaborate to make those decisions together. We may also want to bring some tools into the conversation that will help understand what might be the ways forward that are available to us to improve that situation. When we've experimented by creating the conditions for shared decision making, we have found not only that patients have greater participation and satisfaction in their care, but more importantly, I think, given what I just described, that also clinicians have a higher level of satisfaction with their care, with 75 to 90% of clinicians feeling more satisfied with their care when they're able to work with their patients to come up with care that makes sense. We have also noticed that patients that have lower socioeconomic status, less education and opportunity, benefit more when we offer them tools that allow them to participate to a greater degree in the conversation compared to people who perhaps can find that information on their own. And also we have been able to demonstrate that there is no downstream value for sure when we do this. It's not like patients are going to be better off necessarily or that the cost of care is going to go down. But one of the things that we've been able to demonstrate is that it takes the same amount of time to have an unhurried conversation in which we share decisions than to have what we can see happening in industrial healthcare. And when we make care that makes more sense practically, we can turn around this cruel label into analyzing the situation of Maria Luisa, not Maria Luisa's character, and say that what she's going through is an imbalance of workload and capacity. Not non-compliance, an imbalance of workload and capacity. And immediately you go from, can't do anything for this person, to, oh, I can reduce that workload or boost that capacity and improve the situation. Well, we've talked a little bit about what gives patients work. Let's talk a little bit about what gives patients capacity. The determinants of capacity include purpose. You have no idea how often when I interact with my patients with diabetes and I ask them, what gives you joy in your life? Patients draw a blank. They sometimes cannot tell me what this is. And so you can imagine how that might reduce their capacity to take on difficult work. On the contrary, sometimes people quickly point out, it's my grandchildren. It's my ability to be there for my family. It is my ability to pursue my hobbies or the things that give me a sense of beauty in the world. Purpose is important. Resilience, the ability to bounce back from disappointment. Literacy, the notion that we can take exception from the rules that we were giving. You know, it's 10 o'clock in the morning. I should have taken my pill at 8. If I take it, should I take it now or should I take it tomorrow? Knowing when those exceptions are problematic and when they're okay That's the kind of literacy that I'm referring here. Bandwidth is an issue of attention. If you have to pay a bill by Friday, your mind is going to be focused on that at the expense of everything that's outside of that, which might include some of the self-care that you have to do. So folks that are in a difficult situation may not have the attention that their treatment requires. Physical health, you have a bad knee, it will take you forever to get to the bus station, to go to the hospital, or to go to the appointment. If you have mental health issues, depression, getting out of bed and walking through molasses, it's going to take a long time. And if you have financial difficulties, somebody said that it takes a long time to be poor, because everything you kind of have to do for yourself, you don't have the money to get other people to help you out. If you're socialized or environmentally isolated, all the capacity you have is your own. So with all these determinants of capacity, we can see how people might end up having problems of workload and capacity imbalance. How might we solve them? Well, we can decrease the workload or increase the capacity. What are the things that are available to us? What strategies available to us to decrease the workload? We can prioritize treatments using shared decision making. We can use the platinum rule, not the golden rule of do unto others the way you would like done to yourself, but the platinum rule, do unto others the way they would like done to themselves, which requires us to be curious and seek to understand what matters to the other person. We need to ban medical errands. Again, the notion that we have some challenge in healthcare and we decide that patients and families can do that work. Let's stop that because people are overwhelmed. We need to make sure that when we're using strategies to improve quality like lean, we don't focus just on the production of service, eliminating waste from the production of services, but we also focus on the consumption of those services, making sure that patients and families don't have to navigate a labyrinth of services that take all their time. And when we focus on the digital transformation of healthcare, which is very exciting, we need to make sure that as we move towards that direction, that we don't inadvertently create new work, particularly for patients who are not digitally native. In terms of increasing and improving capacity, there are strategies of patient coaching that actually boost that capacity. Self-management training early in the trajectory of chronic disease can help people develop that literacy that allows them to do more with less. Palliative care, which often is limited to those people who are dying, but it's essential for people with chronic conditions who are limited by a disability or by shortness of breath or by pain or insomnia, and maybe addressing those symptoms can give them more capacity. Physical therapy, occupational therapy, psychotherapy could have the same role. Social work can mobilize community resources in support of the patient or the person that needs all those services. It's not the point that you increase capacity so people can be better patients and can deal with more of the work of being a patient. I have 3 boys, and I've been advising them, even when they didn't want the advice, and I keep asking them, what do you want to do when you grow up? And I've never heard them say, I want to grow up to be a great patient. And I think nobody wants to be a great patient. They have other things to pursue, and we need to make sure that they have enough capacity not only to do the work of staying and healthy or recover their health, but that they have enough capacity to respond to the demands of life, which is really where the action is. Doing it this way, addressing and pursuing patient goals while keeping the healthcare footprint to the smallest possible level is what we call minimally disruptive medicine. These ideas of shared decision-making and minimally disruptive medicine occurring in unhurried conversations has been picked up by an international consortium that put together this manifesto. And in this manifesto, they're giving us a north, they're giving us a goal, the goal of making care fit. And in it, they say patients and clinicians must collaborate in designing care plans that maximally respond to patients' unique situation and priorities while minimally disrupting their lives and their loves. That's the north of care that we have to pursue, and we need to work together to change the conditions to allow for that care to happen. At Patient Revolution, we are committed to that goal. We started in 2015, laying the foundation for our organization and offering now programs and services to fuel a global movement for care. We hope that in 100 years, by 2121, this global movement would have achieved our goal, which is careful and kind care for all, everywhere. To achieve this, we're convening a community of revolutionaries. We are sharing our language and knowledge and insights into what might need to happen to achieve this goal, and we are partnering with individuals and organizations to bring about this radical change, this revolution. And we're not using that term because it's cute, but because we really mean that in order to achieve that goal, we have to turn away from the industrial processing of patients. We have to turn away from industrial healthcare and move towards this idea of careful and kind care for all. So how can we do that? One of the ways in which we can do that is by noticing these pathologies of care, noticing hurry, blur, cruelty, burden, and then figuring out how might we achieve their antidotes by making care the core purpose of healthcare, looking for elegance, which is it's not just efficiency of eliminating the waste, but it's also trying to eliminate the haste. It's almost like a gymnast or a ballerina, where you see them, they're not wasting any movements, but they're also not going faster than the music that is set for their routine. And care has its own music, its own rhythm. And if patients and clinicians can dance to that rhythm without wasting any time, but without going so fast that they no longer can recognize the song they're dancing to, that's what we call elegance, and that is the antidote to hurry. Seeing patients in high definition and responding to their needs in appropriate ways, and doing so in minimally disruptive ways. These are the antidotes to those pathologies of care, and to change them, we need radical cultural change at the level of organizations and at the level of healthcare, in the rhythm, in the noticing and responding, and in the work of patients and clinicians. How we will know that we're making progress? What will be early signs of success? This is a photograph from a season 6, episode 1 of The Resident, a TV show, and this is the fictional CEO of the hospital. On her desk, a copy of Why We Revolt. An early sign of success, in my opinion, except it would be nice if it was not a fictional CEO, but a real CEO. What might be other signs of success? We often hear in hospitals and clinics that, well, we need to see more patients so that we can make the money that we need to achieve our goals. But that's upside down. We need to have enough money to see more patients. So we need to turn that around and make sure that care is not the means to the ends of industrial healthcare, but in fact, care is the purpose of healthcare organizations. We need to invert the accountability. We hold patients and clinicians accountable for the production of outcomes of care. And those who hold them accountable, in fact, should be accountable for creating the conditions for patients and clinicians to be able to care in appropriate ways. We need to flip the accountability arrow. Cruelty should be a never event in healthcare, and we must eradicate cruelty from healthcare, particularly that form of cruelty which is very challenging, which is indifference. When you come in suffering and what you get in return is indifference. They say that the opposite of love is not hate, but it's indifference. And it's the same with the opposite of care. And we will know we're making progress when we see an increasing prevalence of unhurried conversations. This will be the early signs that our movement is succeeding. That our movement is moving healthcare away from motivations based on greed to motivations based on solidarity, from rules and regulations to professional integrity, from efficiency to elegance, from care of patients like this to care for this patient, from overwhelming healthcare to minimally disruptive care, and from transactional interactions to relationships of love. That's what we're pursuing in the patient revolution. We are moving together towards careful and kind care for all. Thank you for your attention.